study about the drug-related changes in different GI biopsies. So the overview of today's class is about, first is the introduction, the drug-related changes in the upper GI tract and the drug-related changes in the lower GI tract, colonoscopy-related injuries, chemotherapy-related injuries, and the how should we approach to a diagnosis, and then the summary. So first, introduction. So as we all know, GI biopsies are among the most frequent types of specimen that we see by a pathologist in our daily practice. So we know currently we get around 10 to 12 cases of GI biopsies, and most frequently we obtain so many cases. So in that, we should be able to diagnose what are the changes, what are the different conditions. Ulcerative colitis is there, different ulcerative colitis, IBD, Crohn's disease, different cases, carcinomas, all these we should be able to diagnose. So in this, we should know that what are the different correct diagnosis of what are the changes that is induced by the drugs. So mainly we will be dealing about the drug induced changes in the GI biopsies. So these histological changes can be, it is overlapping, and the different drugs have a different pattern of injury. So according to the drug formation, the drug dosage, and the length of the treatment, and the pre-existing conditions that is seen in the host, and the intrinsic host sensitivity, the interactions of other medications, all these will affect the different changes that is seen in the GI tract according to the different drugs that is taken. So it is not only, it is a collaboration, or it is an interconnection or an interlink between the treating clinician. So we should always ask the treating clinician what are the treatments that the patient is on, and then the pathologist should integrate with the microscopic findings. Hence only the diagnosis of the medication induced injury can be made out. So what are the different patterns that we see in GI biopsies? So when we see a GI biopsy, we can see a reactive or an hyperplastic epithelial change or a degenerative change. So we can see reactive changes, we can see hyperplastic epithelial changes, and then we can see degenerative changes. Then we can see erosions, ulcerations, fibrosis, or necrosis. So ulcerations can be there, fibrosis is there, necrosis, then lymphocytic and eosinophilic inflammatory infiltrate, apoptosis. Then next it is the different drug fillers. So the drug apoptotic changes can be seen. Then drug fillers, so certain components of the drug, certain pigments, crystals, all this will deposit in the pigment or crystals will deposit, and it will cause histological changes. So these are the different typical patterns that we see. So we should be able to identify what are the different drugs also, what are the different drugs, and what are the different patterns of injury which is caused by each drug. So first we'll be talking about the drug related changes in the upper GI tract. So when we are saying in the upper GI tract, first in the esophagus. In the esophagus we'll be seeing pill-induced changes, sloughing esophagitis, and bisphosphonate associated esophagitis. So pill-induced esophagitis, it is called as pill esophagus. It is an iatrogenic esophagitis due to continuous intake of different drugs. Which are the different drugs, or which are the different pills that we are having? Potassium chloride, NSAIDs, tetracycline, doxycycline, iron supplement, bisphosphonates, and injection of any sclerosing agent or any cytotoxic chemotherapeutic agents. So all these, due to the chronic usage of all these drugs, we can develop pill esophagitis. So it risk factors of patients who is having esophageal motility disorders or esophageal stenosis. It is seen in the mid and distal esophagus. What are the symptoms that the patient will present with the clinician? The patient will present with odynophagia and retrosternal pain. Endoscopy, we can see there is erosions and ulcerations can be seen. So this is the microscopy findings that we see in case of the pill-induced esophagus. We see the reactive squamous epithelium with fibrin and inflammatory cells. So here we can see fibrin, and different inflammatory cells, and this is the squamous epithelium. So we can see a reactive squamous epithelial changes can be noted, and then there is fibrin deposition, and then there is mild inflammatory infiltrate can be seen. So when we see in a polarized microscope, we can see these pill fragments can be highlighted by the polarized microscope. So that is a pill esophagitis. That is the changes in the esophagus. Next we have is the sloughing esophagitis. Sloughing esophagitis is also known as esophagitis desiccans superficialis. So it is called as it is caused by different drugs. Drugs like which are the different drugs that can cause the sloughing esophagitis? CNS depressants, antipsychotics, benzodiazepines, opioids. So patients who are on all these drugs or for a long term associated with different comorbidities are the risk factors. Site is in the middle and distal third of esophagus. These patients can develop sloughing esophagitis. Symptoms is dysphagia, regurgitation of mucosa, and endoscopy. What we see is the endoscopy. We will see a sloughing membrane of desquamated epithelial layer. So a membrane of a desquamated epithelial layer will be seen on endoscopy. So in microscopy we will see the squamous epithelium which is two-toned, and that there is a necrotic material colonized by the bacteria, yeast, and parakeratosis. So this is a sloughing membrane. So we can see here a membrane can be seen, this whitish strips. We can identify these whitish strips can be seen, which is into the lumen of the esophagus. So and then we can see the epithelial split which is above the basal zone. So this is the basal zone above which we can see a epithelial split can be identified. So here you can identify an epithelial split, and then there is parakeratosis, and there is mummified superficial layer resulting in two-tone epithelium. So there is a parakeratosis, and this superficial layer is mummified, so there is a two-tone epithelium. So next it is called as bisphosphonate esophagitis. So due to we know the drugs such as alendronate, risedronate, or NSAIDs, patients who is on mostly osteoporosis patients or Paget's disease patients, these patients are on continuously on bisphosphonate. So this causes bisphosphonate esophagitis. So the site is mostly in the stomach and duodenum. There is ulceration, inflammatory, and necrotic tissue with granulation tissue. So microscopically we will see ulcerations, inflammatory, necrotic tissue, and tissue with granulation tissue is seen in case of bisphosphonate esophagitis. So here we can see the esophageal segment mucosa will be, this is an esophageal segment mucosa which is red and with ulcer formation of different shades, and there is circumferential or distributed along the esophageal wall in circular or varying in size. Then the surface is covered with prominent dense and thick white pseudomembranous exudate. So here we can see dense and thick white pseudomembranous exudates can be seen. So these are the findings we see in case of bisphosphonate esophagitis. Then so here what are the microscopy findings? Microscopy we can see granulation tissue with capillary formation and inflammation. So we can see granulation tissue formation, and reactive changes are also seen. Next is the iatrogenic gastritis. So what is iatrogenic gastritis? Due to different drug induced changes, what are the different gastritis that we see? So first it is different things that we see is reactive gastropathy, gastric calcinosis, then proton pump inhibitor associated gastropathy, iron gastropathy, lanthanum carbonate deposition gastropathy, non-target C distribution, and erosive gastritis. So this is the different gastric changes that we see. So what is reactive gastropathy, gastric calcinosis, proton pump inhibitor associated gastropathy, iron gastropathy, lanthanum, and non-target C distribution, erosive gastritis. So this is called as reactive gastropathy. This reactive gastropathy is also known as C gastritis or chemical gastritis. Drugs, which are the drugs which is causing NSAIDs, corticosteroids, patient who is on long term on NSAIDs, corticosteroid, bisphosphonate, all these drugs. So these patients can develop reactive gastropathy. So what are the risk factors? If there is an alcohol abuse, these patients can develop reactive gastropathy. Then if there is a portal hypertensive gastropathy or gastric antral vascular ectasia, what are the endoscopic findings we see? Mucosal edema, redness, hyperemia, erosions, and ulcerations. So this is so what do we see in case of reactive gastropathy? Microscopy, what we see is that the antral mucosa with corkscrew like foveolar eyebrow. So we get a GI biopsy, and what we typically see here is that there is corkscrew like foveolar hyperplasia. So there is a corkscrew like foveolar. So this is the corkscrew appearance. So we can see corkscrew like foveolar hyperplasia, and there is some reactive epithelial hyperplasia. So there is reactive epithelial hyperplasia, then mucin depletion, and interfoveolar smooth muscle hyperplasia. So here you can see interfoveolar, here we can see interfoveolar. So these are all the gastric foveolars, and there is interfoveolar smooth muscles are hyperplasia. Smooth muscle hyperplasia is seen, and there is, so here we can see some erosions, and so these are the findings. So typical most important finding is the antral mucosa show corkscrew like foveolar hyperplasia. So if we see corkscrew foveolar hyperplasia, we shouldn't think it is any other reactive changes or reactive atypia. It is just a corkscrew like foveolar hyperplasia which is seen in reactive gastropathy, mostly associated with drug intake. So here we can see full erosion of the antral mucosal surface. Then we can also see intestinal metaplasia. We shouldn't confuse it with other like dysplastic changes, all this. So it is just intestinal metaplasia with corkscrew like hyperplasia. So then we can see is acute hemorrhagic and erosive gastritis. So patient who is gastric erosion with an ulcer, that is gastric erosion with an ulcer that has not penetrated the muscularis mucosa. Multiple erosions are found in the mucosa that bleed profusely. So this acute hemorrhagic and erosive gastritis, it is characterized by gastric erosions and the ulcer, and there is an ulcer is there, but the ulcer has not penetrated the muscularis mucosa, and there is a multiple erosions are found in the mucosa that bleeds profusely. So where do we see these hemorrhagic and erosive gastritis? We see patients who was on alcohol, aspirin, NSAIDs, then associated with stress condition. So there is a superficial epithelium is lost in the gastric mucosa, and there is inflammation with we can see here profound inflammatory infiltrate of neutrophils are seen. So this is the typical microscopic findings in acute hemorrhagic or erosive gastritis. Next is gastric calcinosis. So what are the changes we see in gastric calcinosis? There is, what are the causes of gastric calcinosis? Hypercalcemia, hyperphosphatemia, chronic kidney disease, malignancy. So all this will cause gastric calcinosis. What are the findings that we see? We see subepithelial extracellular basophilic crystalline aggregate. So crystalline calcium aggregates can be seen, which is subepithelial. It is this aggregates consist of calcium, phosphorus, aluminum, chlorine, and is surrounded by macrophages. Site is the antral and esophageal. So here we can see subepithelial crystalline basophilic aggregate. So here you can see some subepithelial, these are this crystalline basophilic aggregates can be seen. Here this is the calcium crystalline, subepithelial basophilic crystalline calcium deposits can be seen. It is made up of calcium, phosphorus, aluminum and chlorine, and it is surrounded by macrophages. The site can be in the antrum or in the esophagus. Next, the most important, that the common scenario that we see in our clinical practice for our pathologists is a proton pump inhibitor associated gastropathy. So what happened is that the proton pumps, these target mainly the H plus K plus ATPase in the cell membrane of the parietal cells of the stomach. So we know in the stomach there is a H plus K plus ATPase is there. So these are targeted by the proton pump inhibitors associated gastropathy, and these H plus K plus ATPase are targeted, which is seen in the parietal cells of the stomach, and it will suppress the hydrochloric acid secretion. So what happened is that when the patient is on proton pumps, the gastric acid, hydrochloric acid is suppressed, and the gastric pH level rises, and there is increase in the gastrin secretion. So this causes the protrusion of the parietal cells. So because the H plus K plus ATPase pump in the parietal cells is suppressed and hydrochloric acid secretion is diminished, resulting in the protrusion of the parietal cells into the lumen of the oxygenetic glands and giving a serrated appearance, and thus the parietal cells will get protruded, and there is a dilatation of the gastric glands, and there is vacuolization of the parietal cells, and this causes the development of Fundic gland polyps. So here you can see associated with proton pumps, Fundic gland polyps are seen. So this is the oxygenating mucosa which is which shows dilated Fundic glands which is lined by hypertrophic or we can see hyperplasia, where plastic parietal cells with the apical luminal snouting and protrusions with prominent cytoplasmic vacuolizations. So this is the Fundic gland polyp which is induced by proton pump inhibitor. So this is the gastric mucosa which is showing dilated oxygenatic glands with parietal cell hypertrophy and hyperplasia. So this is a Fundic gland polyp with cystically dilated and hyperplastic parietal cells which is spreading up to the pits. So next is iron gastropathy. So this is iron deposit. So patient who is on iron therapy. Extracellular iron aggregate are induced by oral iron supplementation. So oral iron supplements the patient is having for long term, resulting in extracellular iron aggregate. Then macrophages laden with iron from prior inflammation or mucosal bleeding. So these iron deposits in the gastric mucosa can be seen in 3 different patterns. It can be seen as extracellular iron aggregate, which is extracellularly this iron can be deposited, which is induced by oral iron supplement. Then macrophages laden with iron. Macrophages will be laden with iron in case with prior inflammation or mucosal bleeding. Then the deposited in the epithelium of antral or Fundic glands related to systemic iron overload. So associated with oral iron, we see extracellular iron aggregate. Then associated with prior inflammation or mucosal bleeding, the bleeding which is causing the excess iron will cause macrophages will be laden with iron. So why do we see hemophage or iron deposit macrophages? It will be associated with prior inflammation or mucosal bleeding. That is a cause for the deposition of pigment laden macrophages we see. It indicates that there can be a prior inflammation or there is a mucosal bleeding. Then the deposition of iron in the epithelium of the antric and frontal gland, that is so if the iron is getting deposited, it is related to systemic iron overload. So if it is extracellular deposit, it is oral iron supplements is causing this. Then macrophages is associated with prior inflammation or mucosal bleeding. Then if it is depositing in the epithelium of antral or Fundic gland, it is related to systemic iron overload. So endoscopically we see yellow-brown discoloration of the mucosa, mucosal defect or erosion in the ulcers can be seen. So the microscopic finding, mucosal erosions with brown, black, granular or fibrillar crystalline material overlying the eroded epithelium, and Prussian blue distinguish it from the others. So what we see is that mucosal erosions are seen with brown, black, granular or fibrillar crystalline material. So the erosions with brown, black, granular or fibrillar material can be seen. So here you can see the brown, black, fibrillar material, and there can be erosions with eroded epithelium, and then there is distinct blue appearance of iron. So what are the stain? Which stain do? We will do the Pearl's Prussian blue. We will identify, and Pearl's Prussian blue can be done, and this blue deposits helps to identify iron. Okay. Next is the lanthanum carbonate deposition, which is this lanthanum carbonate is mainly given for the treatment of hyperphosphatemia and end-stage renal disease. This due to having these lanthanum carbonate drug, which is a phosphate binder. This is so it will get deposited in the stomach, duodenum and colon, and resulting in whitish lesion. So if there is a clinician gives us a history of lanthanum carbonate treatment, then we have to carefully see whether lanthanum carbonate deposition is there, and this is causing the whitish lesion on endoscopy. So microscopy, yellowish brown amphiphilic deep purple blue crystals can be seen. Next is due to patients who is undergone intense internal radiation therapy. So these patients will have microspheres which is emitting carrying beta emitter reactant. These microspheres, we can identify these microspheres in the lamina propria and in the submucosa. In the lamina propria and in the submucosa, here you can see these microspheres. Here we will also see reactive epithelial changes and hyalinized lamina propria and prominent ectatic vessels. Here you can see prominent ectatic vessels and dark brown microspheres. Then next, by poisoning. So patient who is on any cyanide poisoning, what do we see the features? We see pink hemorrhagic gastric mucosa can be seen, and vasocongestion, hemorrhage and necrosis, submucosal hemorrhage and necrosis, and sloughed off mucosa. Then drug related changes in the colon. Next is the drug related changes in the colon. So we finished the drug related changes which is seen in the upper GI. So next video I will be dealing about drug related changes in the colon. So which are the drug related changes in the colon? Microscopic colitis, ischemic colitis, pneumatosis coli, melanosis coli, eosinophilic colitis, and pseudomembranous colitis. Okay, thank you.